Hey peeps, welcome to the final part of the endometrial cancer series of the NCCN guidelines review. And today we'll be going over carcinosarcoma. Let's get to it. So in the past, carcinosarcoma was categorized as a sarcoma. If you look at the NCCN guidelines, they break up two large categories as carcinoma and sarcoma. And carcinosarcoma, as the name implies, used to be in the sarcoma category. But now we know that the carcinomatous component of the carcinosarcoma is what dictates tumor behavior. And so it's now categorized as a high-grade endometrial carcinoma. And so you'll see that the staging has shifted, and no longer is it staged in sarcoma staging, it's in the carcinoma staging. We know that carcinosarcomas are very aggressive. About 50%, greater than 50%, present with distant mets, and then even in early stage disease, about 10 to 15% will have lymph node mets. And let's look. So I just wanted to remind you about GOG33. Go back to my early stage endometrial cancer lecture if you want to know more about the entire trial. But GOG33 looked at pathologic characteristics of stage 1 endometrial cancers, with an emphasis on nodal metastases and how prevalent they are in different characteristics. So look at a grade 1 endometrial cancer, percentage of pelvic lymph nodes, 3%, and then as you get higher, up to 18%. And then also they also looked at depth of invasion and pelvic node mets, which are relatively low comparative to carcinosarcoma. So that's kind of what I wanted to highlight here. I would say carcinosarcoma is more like grade 3, which we already said. It's more of a high-grade carcinoma and has a high rate of lymph node mets. Carcinosarcoma has a poor 5-year disease-free survival. We're hoping to catch in an early stage because that obviously has the best prognosis, but over 50% of early stage uterine carcinosarcoma, which is UCS, recur and will eventually lead to the patient's death. As far as the pathogenesis, the pathologists reviewed over 200 cases and identified the carcinomatous component, as I said before, as the driving force in the clinical behavior. And that is what shifted us to say that these tumors represent metaplastic carcinomas rather than sarcomas. So as you can see here, they're showing you these tumors they're called biphasic tumors, and they're showing you the different components. So here you have the high-grade serous component. That is going to be the carcinomatous component. And here's the sarcomatous component. And then they're showing you vimentin, which is usually muscle/sarcoma. P53, which is going to go with your high-grade serous component, and then P16. So I thought this was a really nice depiction of the biphasicness of the tumor. Okay, so here is the NCCN guidelines page. Carcinosarcoma has its own page, and at first it just states, consider a CA-125 in imaging, and that is because of the high risk of distant spread nodal mets. So you want to get that information. And then if the patient is suitable for primary surgery, it's just like endometrial carcinoma. You're going to undergo TLH, BSO, sentinel lymph node dissection / staging, or if there's gross tumor, you're going to undergo a maximal tumor debulking. If the patient is not suitable for primary surgery and it's pelvic confined, they'll undergo EBRT plus minus brachy plus minus systemic therapy or systemic therapy, distant mets, systemic therapy. Once they've undergone surgery, then you get to next step, which is systemic therapy plus brachytherapy plus minus EBRT. And so in the next few slides, we're going to go over why we do what we do as far as systemic therapy, as far as adjuvant therapy in general. Okay, so these trials are for early stage adjuvant therapy, stage 1 and 2. we have retrospective data that supports adjuvant therapy in carcinosarcoma, showing that about 50% of patients recur within 6 months, and all the patients who recur end up dying. And so we have some prospective early trials to support adjuvant therapy, and we'll start with GOG20. Since carcinosarcoma was grouped as a sarcoma and treated as a sarcoma, it was included in early GOG trials investigating uterine sarcomas. And so GOG20 included 156 patients with uterine sarcomas. They were stratified by leiomyosarcoma and carcinosarcoma. And this showed that they showed a decreased recurrence in those patients receiving doxorubicin versus no treatment. So those receiving doxorubicin had 38% of recurrence versus those who were observed 51%. Sorry, that is backwards. Then they went on to EORTC 55874. This was a study that compared adjuvant EBRT to observation in uterine sarcomas. There were 224 patients, and 91 had uterine carcinosarcoma, which is a good chunk. The patients received 51 gray in 28 fractions over 5 weeks after hysterectomy BSO with washings and an optional lymphadenectomy. And in the carcinosarcoma patients, there was a trend toward increased local control in the radiotherapy arm versus the observation arm. So 47% recurred in the observation arm and 24% in the EBRT arm, which is approximately a 50% reduction in recurrence. However, no differences in PFS or OS. I do have just a star here about leiomyosarcoma in this trial. If you're listening to this, you should be pulling up the paper. And when you read it, you'll notice that actually leiomyosarcoma in this study, radiotherapy actually had adverse effects in leiomyosarcoma. So we're just learning about all sarcomas here, and that was just a little tidbit. Let's move on to GOG 117. This looked at chemotherapy with IFOS and CIS to assess PFS and OS and toxicity of this combination. It was a phase 2 trial and included 65 patients with stage 1 and 2 carcinosarcoma. And you'll see the 24-month PFS and OS were 69 and 82% respectively. And there were minimal differences between stage 1 and 2 patients. So findings suggested improve outcomes with adjuvant chemotherapy. However, it concluded in the absence of controls, the impact on survival was unclear. So I think the question is, what type of adjuvant treatment should be administered? And we have EORTC, which did show a trend toward decrease in local recurrences with radiation, but it didn't show any differences in PFS or OS. And then we have multiple studies that showed a benefit of chemotherapy. However, they're small trials or phase 2 trials, and they don't have a control arm. And so given there's no phase 3 randomized data evaluating chemotherapy and vaginal brachytherapy versus observation to assess any superiority, it's still a provider-driven decision. I will say, though, that the NCCN guidelines are recommending systemic therapy plus brachytherapy and then plus minus EBRT. And then we move on to advanced recurrent trials. So let's start with GOG 108. This investigated persistent or recurrent advanced stage carcinosarcoma patients, and it was comparing IFOS versus IFOS cisplatin, and it showed that combination chemotherapy was more efficacious. And of the 102 patients who received ifosfamide alone, 36% responded, whereas 92 patients who received combination treatment, 54% responded. The PFS was improved in the combination group. It was a 6-month versus 4-month PFS. The response rates did not result in an overall survival benefit in this trial. And so then we'll move on to GOG 161, a similar cohort and of advanced recurrent patients, and it examined IFOS versus IFOS paclitaxel. The overall response favored the combination arm, 45% versus 29%, and PFS mirrored GOG 108, 6 months versus 4 months. But the OS for this regimen was statistically significant. It was longer in the combination group at 14 months versus 8 months, which showed an added benefit with the combination of paclitaxel. This then led to examining ifos-Taxol. Some of the things about it, though, is it's difficult to administer. It's over 3 days. You do need growth factor, and it also has a neurotoxicity risk, which we'll talk about here on the next slide. So not ideal, still would be good if we could have a different regimen that maybe didn't have so much difficulty, risk, toxicity issues. And then came GOG 232B. This was a phase 2 trial which investigated the safety and toxicity of carbotaxol in stage 3 or 4 patients. And the overall response rate was 54%. The PFS was 7.6 months and the OS was 14.7 months. When compared to GOG 161, that was improved. One tidbit before we move on to the next trial, and just a quick reminder about ifosfamide. So we all know it's an alkylating agent in the same category as cyclophosphamide. And the two big toxicities that I want to talk about here, one is encephalopathy. The risk of encephalopathy is one of the main reasons why we keep patients inpatient when administering ifos. It is a potentially fatal side effect. You can see symptoms from confusion, disorientation, hallucinations, seizures, to coma, to even death. One risk factor is hypoalbuminemia. So always be looking at patients' albumin prior to giving them ifos. And then the treatment is methylene blue. The exact mechanism is unclear how it treats this, but it acts on the metabolic pathways, the same ones of ifos-induced encephalopathy. So please consult your pharmacist when you're starting someone on ifos and make sure that you have a protocol in place. The second one, and probably more familiar from us, from board studying on step 1, is hemorrhagic cystitis. So the cause of hemorrhagic cystitis with ifos or cyclophosphamide is acrolein. Acrolein is a caustic metabolite that is the responsible one here. It causes a reaction to the bladder epithelium that leads to ulceration of the bladder and therefore hemorrhagic cystitis. We use Mesna as a uroprotective agent. It neutralizes acrolein by binding and inactivating it. It's used preventatively. Mesna is given before the ifos during infusions. And each day we get a microscopic urinalysis to look at red blood cells per high-powered field. And we want it to be less than 10. If it is greater than 10, you start to have a concern of hemorrhagic cystitis and start loading up on the hydration. So those are the main things. There are obviously other toxicities, myelosuppression, nephrotoxicity. UpToDate has a really nice sarcoma. It's talking about doxorubicin and ifosfamide, but it has the regimens and it has all of the toxicities and what you would do. So I would recommend that you go look that up on UpToDate. It's excellent. Okay, onward. So to one of the most important trials, this is GOG 261. It followed these trials that we had just gone over, and it was a phase 3 trial. It was non-inferiority comparing carbotaxol versus ifos-Taxol. So it took the past regimens and it kind of put them head to head. And so when comparing the two, the PFS was 16 months versus 11.7 months. And the OS was 37 months versus 29 months, respectively. But the advantages to the carbotaxol combination were convenience, less bone marrow toxicity, a better cost profile, and overall less toxicity. There was no difference in quality of life data between the two, and the trial concluded that carbotaxol was non-inferior to ifosfataxol. So based on the results from 232B and 261, carbotaxol is now the recommended treatment, first line, for carcinosarcoma, not due to non-inferiority, better toxicity profile compared with ifosfataxol. Okay, so we just went over how we got to where we are in carcinosarcoma. This is from NCCN guidelines, systemic therapy, preferred regimens, and I edited it to be specific to carcinosarcoma. So carbotaxol, GOG 261, we just went over it. Carbotaxol pembro for stage 3 to 4 tumors except carcinosarcoma. This is GY018. Go back to the advanced endometrial cancer lecture if you want to learn a little bit about that. But the Ruby trial, notice that it doesn't say except for carcinosarcoma, did include carcinosarcomas. So carbotaxol dostarlimab is a regimen that can be used in carcinosarcoma. And then I wanted to put a quick plug in here for Amanda Nichols-Fader phase 2 trial, which was carbotaxol trastuzumab for uterine serous carcinoma, which we'll go over just a quick reminder of what that trial was before looking at GY026, which is now ongoing for carcinosarcoma and uterine serous. So a reminder of this beautiful chart and where carcinosarcoma falls into Ruby. So again, go back to the advanced endometrial cancer lecture if you want to learn more about that. But carcinosarcoma was included in that trial, so keep that in mind. Okay, and a quick reminder for context. This phase 2 paper from Amanda Nichols-Fader in 2022, this was a trial that included stage 3-4 recurrent HER2 positive uterine serous cancers. Not carcinosarcoma, we're talking about uterine serous here, and I'll tell you why. This trial looked at carbotaxol for 6 cycles plus or minus trastuzumab. So the groups was yes or no trastuzumab. And the primary endpoint was PFS. The patients were randomly assigned, and the median progression-free survival was improved by 4.6 months, as you can see here, 8 months versus 12.6 months, in patients who received trastuzumab with carbotaxol compared to those who just received carbotaxol alone. So in conclusion, the addition of trastuzumab benefited patients with advanced disease in the primary treatment setting. And you can see here on this Kaplan-Meier curve, the patients who got trastuzumab, there's a clear difference. That leads us into GY026, which is a phase 2/3 study looking at carbotaxol combined with either trastuzumab and hyaluronidase, or pertuzumab, trastuzumab, and hyaluronidase in HER2 positive stage 1-4 endometrial serous or carcinosarcoma. So a significant portion of uterine serous and carcinosarcomas demonstrate HER2 amplification or overexpression. And there was a demonstrated benefit from that phase 2 trial that we just went over, with the greatest benefit seen in chemo-naive patients. So this is currently enrolling GY026 with chemo-naive patients, non-recurrent, in patients who are HER2 positive. So this will be exciting to see what comes out of this. And then also on the same lines of HER2, Destiny Pan Tumor 02 also was just released, and this was an open label phase 2 study for the treatment of previously treated HER2 expressing tumors. And this trial included biliary tract cancer, bladder cancer, cervical cancer, endometrial cancer, ovarian cancer, pancreatic cancer, and other solid tumors. And it looked at trastuzumab deruxtecan, otherwise known as Enhertu. And this is given every 3 weeks, and it was HER2 expressing tumors, IHC 3+ or 2+ on IHC, with locally advanced or metastatic disease, and they had one or more treatments in the past. Their primary endpoint was objective response rate, and I just put this in here. This was from NCCN because this is in NCCN guidelines. And so this is a really pretty chart. I think I like it because of the colors, but I want you to focus here on the endometrial cancer data. So the confirmed overall response rate of all patients was 57.5%. And the primary analysis of the trial showed that there was a greater response rate seen in patients with higher levels of HER2 expression. So the IHC of 3 showed a higher level of response than IHC 2+. But regardless, was a very positive overall response rate for this patient population. And so take a look at it, print it out. And like I said, it is already in the NCCN guidelines. Whew. Okay, that seems like a lot of information. This paper here, I would recommend if you're not going to read any of the trials that I just talked about, I recommend that you do. Don't take anyone's word for anything and read everything yourself. But this paper is a very nice summary. It's not the most up-to-date. You're not going to see GY026 or the Destiny trial in either of these. However, it is why we do what we do. It will flow through this presentation just like that paper. It's excellent. UpToDate also has a very nice breakdown of how we got here. And then this is one of the trials that I mentioned. I named all of the trials that I mentioned in all. So please reference the GOG numbers if you're going to go look them up. And if you are having trouble finding it, then please let me know. But I hope this was helpful. This was an amazing review for myself. And to be honest, I'm basically making these for myself to help myself learn. So let me know if you have any questions or anything that kind of caught your mind. And I hope you learned something. Have a great week.